So thanks for joining me. Again, I'm Mike Karasik, Vice President of Oncology for Allina Health System. Today I'll talk about our program and kind of our vision, but also adding that next linchpin in it, a Financial Toxicity Tumor Board. Talk about what's needed in development from stakeholder support, the financial contributions or aspects, proactive patient identification, staff training and tools, and even some of the strategy behind it. So where is Allina Health? We're located in the great polar state of Minnesota, and it still is summer there in western Wisconsin, with over 11 comprehensive cancer sites, surgical, radiation, medical oncology, serving a little over 6,000 analytic cases a year. You know, I hate that word, financial toxicity, but we know from even our internal documentation too, that the anxiety over the finances is often greater than the diagnosis itself. And for us at Allina Health, financial toxicity is also, addressing it is also a population health imperative. Allina Health, not a secret, a large hospital system, actually took a big paradigm shift in terms of contracting during the global pandemic in 2020, and we went with a population health agreement with Blue Cross Blue Shield, and we want to move to other value-based. At the same time, I developed a cancer program, brand new at the time in 2020, so people, places, programs, adding many more doctors and so forth, and we knew that we have to address this terrible word, financial toxicity, but addressing the financial barriers for our patients. We can have amazing care, but we also know with oral oncolytics and all the studies and all these are just some of the impacts here. I need to update these slides. There's some old ones, but we know I've been in oncology now for over 2 decades and started my first patient financial navigation program in 2002. It was all social workers. We had one. And before you knew it, I had 6 social workers, all focusing the majority of their time on this, but realized too that we were early adopters to have navigators, lay navigation too, that it really took a village to address patient financial. That word toxicity is a word too that I've only seen in the last 10 years, but describes it so brilliantly in many ways. So for us at the Allina Health Cancer Institute, our vision here was integral to all our services. Let's be proactive. Let's be there during the whole continuum of care too, to connect patients to financial navigation, to educate them on their financial responsibility. Let's optimize the patient coverage in its many areas, maximize how we can. And here at our conference, there are so many great vendors and resources for external assistance. Also, let's improve our patient collections. You know, for health systems too, they go, what is the return on investment? What's the ROI when we put together patient financial navigation? Number 1 at the top, and I have my own dashboard on this, not only are we saving a huge amount of money for our patients, bad debt has decreased by 25%. That's real money. But one thing that was missing on here was truly that physician engagement. I can introduce, and that is having a tumor board with our physicians, multidisciplinary, and be an extension of breast and colon and GU and molecular and all the various tumor boards just focused on this. Going back, this was in our comprehensive program design. By no means, our cancer is 3 years young, but by no means we didn't want to reinvent the wheel. This conference is older probably than our cancer program, and so we wanted to make sure it's unique. Let's look at ideating a new approach to it, and this was actually one of them. With it is a multidisciplinary approach. I have a patient financial navigation task force. It is made up by by our physicians, including both surgical and radiation oncology also. It's operations, it's social work, it's our 30 patient oncology nurse navigators too, representing there too, pharmacy, lab, nursing, marketing, with a wonderful task force charter too. And our goal was to continue to incubate that success to all of our locations and have both in-person and virtual options. One of our journey milestones, before I jump into our latest one too, I mentioned some of those milestones back in the vision. One of those two is to make it electronic, to have an app also for our Cancer Institute, and working with the University of Minnesota too on an app that's focused just on social work and resources and help with some of the resources. Optimizing patient coverage, I mentioned all of these milestones, but the milestone number 7 that we added in 2023 was the establishment of a Financial Toxicity Tumor Board. So what is, if you're familiar with a tumor board, how is this different? This was established as making sure that it's adjacent to all those regular cancer tumor boards currently. And I mentioned there's over 18 of them, including molecular and even getting down into very specific cancers. But its specific focus is talking about the clinical implications and addressing the financial barriers at the same time. That word, financial toxicity, was specifically chosen. We could have just said patient financial navigation, but it was chosen because I think it describes well the total impact of the financial burden that we know is linked to bankruptcy, non-compliance, which is a big discussion too within the tumor board, poor outcomes, and increased mortality. When I go back to population health, we know that population health too is looking at total. It has now quintuple and growing strategic goals around it. But we know it's minimizing care variation at the very top, and of course addressing total cost of care. This goes right into that, total cost of care, and really trying to minimize that too for our patients, as we know the out-of-pocket costs are extreme. Through this too, we knew that we had to expand our physician assistance program. We wanted to proactively make sure that the availability of free or through sponsor too, free cytotoxic, symptom management, targeted agent. We want to proactively manage the copay assistance, get in front of it. We personally think that every patient is eligible for patient financial navigation. And how do we have enough navigators, both virtually and in person, and resources too, to manage that? How do we manage bad debts too associated with lack of insurance to cover all these complex medication and be there all the way from screening to survivorship, all the way through the continuum of care in oncology, and allow for physical or virtual embedding, including electronic, having an app too, to make sure that we're working with our pharmacy techs, with our oncology pharmacy also, with our physician offices and our infusion sites in conjunction with expanding our patient assistant program. Some of our mechanics here too, it just shows how this this just gives a sampling of our various tumor boards. So, that they're multidisciplinary. Let's just pick on breast, for example. They're talking about breast cases with the radiation, the surgical, the medical oncologist. Now this is adding that unique twist too, separate, just talking about what happens when there's access issue, when someone was denied a medication too, what does that have, and are we making sure that this is being addressed internally? It gives that physicians that needed voice in the room. In the beginning too, we open to submit cases for any financial toxicity tumor board. They must submit at least one case a month. 1 week before and kind of talk about that individual. In the beginning too, this is a new concept. Not all the doctors were like, oh, I don't know about this. This is, it heavier on the medical oncology side, just because they know from the drug impact too. And the big key to this too is having that physician champion, that doctor who's really passionate about patient financial toxicity and talking to the others and saying, this is unique and can lead to clinical collaboration. The physician themselves. And we have cancer coordinators. It's like the scheduler with registry. It's going to work the same way that we'll set this up. Electronic health systems now, I think, it's all tumor boards are all virtual. It's COVID, the impacts has made that all virtual and set up in advance. So I'm not a clinician, but I'm going to go over a couple of examples that would come to the board, and these are truly just examples. One, starting breast, it's always going to be our largest tumor board too, our largest for any program too, our largest our tumor site. In this case here, looking at, with also some fellows in the room, the scenario here was it was 83-year-old with HER2 negative invasive breast cancer. Did not receive insurance denial. ED visits, office visits added up. Patient is primary caregiver for her 88-year-old husband with dementia. She decided to not get further chemotherapy as she felt that preservation of her function was critical. That's a tough one too. Some of the patient implications, this is kind of how the tumor board looks at these, is that patient did not receive growth factor with her diagnosis due to insurance denial. This led to profound neutropenia with recurrent ED visits. When we go back to population health and minimizing the cost, even the variation in clinical care, and make it with that unique focus too on survivorship and palliative care too, ED and hospital visits, as we move from volume to value, is one thing that my program, I know that other programs are looking at too, minimizing it. We know that through the OP35 data too, with CMS that tracked ED and ER utilization in hospitals for the past 5 years, show that this is a huge component of cost. So when I footnote that, that recurrent ED visits and hospitalization, for us, we're trying to keep that at a minimum. And a lot of different things in play, from oncology navigation to apps to patient education, to minimize that and that huge cost associated. In this case too, the patient chose not to continue further chemotherapy. She could have avoided ED visits and hospitalizations as discussed at the tumor board had she gotten that growth factor, and that was the big question. At the same time too, the board looks at system implications. Had she received the growth factor, could she have potentially avoided those expensive ED visits? For oncology too, I'll go further that most ED or ER visits for an oncology patient, it's just the wrong setting. Oftentimes they don't, they don't know not only is it the wrong place for them to wait for many hours under their immunosuppressed, if they're immunosuppressed too, but when they finally get there too, it truly are things that could be handled in advance. Neutropenia, neutropenia to some of the other pieces too, truly minimized by nurse triage and so forth. We put what Neulasta would have cost, and how often do insurance companies deny growth factors? How much time does it take the clinical staff to work on these approvals? And this was early on for us too. This was way over a year ago. And what do we do when insurance denies that recommended treatment. So it wasn't specific again to, it wasn't, sometimes specific to, things that would have been addressed in the breast tumor board, but focused on the financial toxicity. What were the barriers too that changed the whole clinical scenario? In this case, this additional case presentation, 64-year-old patient undergoing adjuvant chemotherapy following surgical treatment for a pancreatic tumor. Upon receipt of the patient's planned course of treatment, the insurance company advised that no pre-certification was required and that the patient then received several cycles of chemotherapy. So this came out. So this was an extension out of that specific tumor committee, because they wanted to talk about what happened when they racked up, when these bills started racking up. Months after treatment began, the patient received notice that the chemotherapy claims had been denied by the insurer, who indicated that the required pre-certification was never obtained. We've seen this too, where they're saying, oh, you don't need that, and then it's denied. And you know what a mess it is behind the scenes and the hours you spend on the phone. I won't talk about the specific insurer too, but it's one of the trouble ones that don't have all the wonderful electronic and support, the ones we spend all our time on the phones on. But following a review of the denied claim, it was noted that one drug in the treatment regimen required pre-certification through the patient's pharmacy benefits rather than the medical plan, which was really outside the norm for outpatient chemotherapy. Per the EOB issued by the patient's insurer, the patient was billed almost $42,000 for the denied medication. We know this leads to anxiety. This addresses some of that financial toxicity, and these numbers now are much bigger than $42,000 and so forth. The patient requested assistance from our financial counseling, our patient financial counseling team, and was presented at our Financial Toxicity Tumor Board. The outcome? The financial counselor secured a retroactive and ongoing pre-certification for the entire course of treatment, really eliminating the patient's financial responsibility or minimizing it. The process was implemented whereby our representative now specifically could confirm that no part of the patient's treatment requires a separate pre-certification through a specialty pharmacy benefits also. Again, it's that mix. It's having the doctors in the room too to help also identify barriers, but also look at solutions too for the patients, that we know that access is hindering total outcomes. We feel again this is an extension again of our population health. Even this huge shift as we look at, as we enter also the oncology enhanced model, the last they say of our CMS alternative payment models, to the shift we're seeing into value from volume. Just in our first 2 years too, we had over 7. We moved up, and our savings of course is huge, and we know that across in this room, even alone, your numbers are huge because oftentimes it has to do with the oncolytics provided. It's also 1.3 million copay assistance provided for our financially challenged patients. So looking back, and obviously it's fairly new, what did we learn? A lot of we already knew into this. Patient financial counseling is not new. It's for me, personally too, it's been something that we've been addressing for decades now. We know that, however, the big things that really exposed it for the system too was lack of health insurance coverage, Medicaid expansion discussion, impediments of reimbursement by insurance, all those pre-certifications needed. As much as we move to clinical pathway utilizing a third-party tool, to other devices too, saying how do we the pre-authorizations and so forth. We know it's not a one-stop solution too. It's based on the cascade of all the insurance requirements too. The small, it's not just the big United and Humanas and so forth of the world. We know there's also an inadequate communication between clinical and non-clinical terms. This is where that Financial Toxicity Tumor Board, getting the physicians in oncology pharmacy in play. It also identified some of the other population health, addressing some of the, diversity too. The challenges just with health literacy, and helped us to focus on specific populations too. It also made us look at financial accessibility of novel therapy. What's this going to look like too as we look at the various forms of cellular therapy, including CAR T in an outpatient setting in the years ahead, and really getting ahead of that financial toxicity, as we know those expenses are even greater. Costs of complex surgical and radiation treatment, lack of awareness of fiscal consequence of treatment, and even looking at precision medicine. All those components of it too, which also have huge patient out-of-pocket costs, making sure that we're maximizing translational studies for our patients, but also unplanned diagnostic testing costs, and even the radiation and the total bill too, captured in our patient financial navigation program, again from screening all the way through our continuum of care. Other lessons learned to share too was just knowledge. We learned that multidisciplinary discussion of financial toxicity is comparable to the clinical management setting. It truly improves patient care, access, education, and really strengthens the healthcare system, especially for ours too, as we shift again to value and even population health initiatives. We learned that by identifying and discussing patient financial issues too, we could correct most problems. It also gave us greater wisdom. We let go of the concept that understanding and managing financial toxicity is irrelevant for clinicians and unworkable across a large healthcare enterprise. We're new to this, and we're learning a lot of lessons. I think that's a wonderful thing about this conference too, is the power of networking and sharing solutions. By no means, I'm not a pro at this. This is brand new, this tumor board, but it gave us, again, that seventh tool to use. That what is our vision long term to make it the best, our patient financial navigation program.